Good afternoon, everyone. So I'll be presenting today's clinical grand round on the behalf of Department of Dermatology and Venereology on the topic of Xeroderma Pigmentosum. This is a work we started 3 years back, and hopefully we were able to impact the lives of the children affected with this disease to some extent. These are children called as children of the moon. These are children deprived from their right to sunlight. And these are children looking for help. Like any other genodermatosis, it requires a multidisciplinary management. And we are blessed with a compassionate team from the departments of pathology, Professor Sudhir Rava and Senior Resident Dr. Shivangi, ophthalmology, Professor Namrata Sharma ma'am and team, genetics, Dr. Madhumita, Madhulika ma'am, Dr. Neerja, and bioinformatics, Dr. Amit Katia. In today's CGR, I'll be introducing the topic and giving some clinical data. Madhumita ma'am has come here to discuss the genetic aspect of the disease. I am highly obliged Professor Namrata Sharma has joined us to discuss the ophthalmological complication of the disease. My friend Ria will be discussing about the dermoscopic analysis of these patients. And me and Sudhir sir, we are working on the tumor, on the histopathology of the tumors, and we will be discussing about the pathological analysis. And in the end, Professor Somesh Gupta, a senior colleague from our department, will be discussing surgical management of the tumors in these patients. We all know that this is a rare genetic syndrome characterized by defective nucleotide excision repair pathway, a pathway which is required to repair the sun-damaged protein. So this results in extreme sensitivity to UV-induced damages in the skin and eye, and make them very prone to develop cancers in the skin and ocular tumor. It is a rare disease. From India, there are no population-based studies, but we could find a review article in 2015 mentioning that 37 families have been reported till then. The numbers must be higher now. So nucleotide excision repair pathway, it can be divided into two sub-pathways, which are global genome defective pathway and transcription coupled nucleotide excision repair pathway. And defect in them results in accumulation of the proteins which are mutagenic as well as cytotoxic, resulting in premature aging and malignancy. There are 8 different complementation types, and they are important because they differ in the photosensitivity they experience, and thus resulting skin cancer, the occurrence of skin cancer, and ophthalmological and neurological complications. Variants like XPA, XPD, who have severe photosensitivity and sunburn, children usually follow vigorous sun protection, thus there is a delayed occurrence of skin cancer and minimal ocular complication, but neurological complications are more frequently seen. Variants like XPC and E, where the photosensitivity is mild, the sun protection is suboptimal, results in increased occurrence of skin tumor, ocular tumor, but neurological complications are rare. This is the largest cohort worldwide, which has been followed up for the longest period, and it shows that the children, they have 10,000-fold increased risk of development of non-melanoma skin cancer and 2,000-fold increased risk of development of melanoma. And in the graph, we can see that the mean age for sporadic population developing non-melanoma skin cancer is 67 years compared to 9 years in patients with XP. Similarly, for melanoma, the mean age in general population is 55 years compared to 22 years in patients with Xeroderma Pigmentosum. We can see that age of 12 years, at least 50% of them will have either a non-melanoma or melanoma skin cancer, more so in the type which do not burn, especially type XPC and XPE. And there is a reduced life survival as well. According to this study, 30% of XP patients died by age of 32, which is much less than the general population. The sun protection is the mainstay of the management. This is one of our patients practicing strict photo protection, but we know that this is difficult. And there are studies worldwide showing that the sun protection is suboptimal in this cohort. This was a study from UK which was done on 36 patients to evaluate various clinical and psychosocial factors determining their sun protection behavior. And they found that there were various clinical factors and psychosocial factors affecting positively or negatively to this behavior. The factors like being older when diagnosed, not experiencing a sunburn phenomena, and holding a strong belief that clinical treatment can control XP affected it negatively, while knowledge that XP is a lifelong disease, accepting the necessity of photoprotection, and incorporating an automatic behavior to do so was associated with positive sun protection behavior. Last year, based on these factors, they have created this behavioral model to so that they can follow a strict photoprotection in this cohort. Isotretinoin we know has a chemoprophylactic role. It reduces the recurrence of tumor by significant 63%. But we can see in the graph during the isotretinoin on phase, the tumor recurrence is very low. But as soon as you stop it, there is significant increase in the number of tumor. It increases by 8.5 fold. So a lifelong treatment is required. Imiquimod topical 5% imiquimod we use in sporadic population for the management of pre-malignant and malignant lesions. Similarly, for XP patient, it is an important adjunct for the management of skin cancers. This is a departmental study showing use of topical imiquimod as an immunopeeling agent for resurfacing of the skin. They have recommended 4-month alternate day use followed by weekly or twice weekly use for the maintenance. And rest of the study, rest of the literature focuses on newer therapies for the management of the skin cancer, and also there is a possibility of gene therapy. When we started this ICMR project and started looking after these patients, we recruited 28 patients of Xeroderma pigmentosum till now. Out of them, we can see that 25 patients we have genetic diagnosis available. 21 of them are from XPC variant. So this is the most common variant in our cohort. 2 had XPA, and in 2 patients we could not identify the complementation type, and rest 3 patients the genetic diagnosis is still pending. The majority of the patients in our study belong to western, central and eastern part of the country, and 57% of them had cancer, current or past episode. We evaluated their sun protection behavior based on this score, which is an 8-item Likert type scale. The score ranges from 1 to 5, and the maximum score means better sun protection. And our patient had a moderate sun protection, which improved further on continuous follow-up and repeated counseling. As expected, there was significant impairment in the quality of life for these children and significant impairment in the family quality of the life for the children. I will invite now Madhumita ma'am for discussing the genetic perspective of XP patients.
Thank you, Dr. Neetu. So, good evening to all. I'll be presenting the genetic perspective in Xeroderma pigmentosum. So, XP, as discussed, it's a rare DNA repair defective disorder having autosomal recessive inheritance. That means both males and females have can be equally affected, and they have 25% chance of having an affected child. It affects people from all continents and all racial groups, and worldwide the population frequency is estimated to be 1 in 1 million in US and Europe, and it has a higher frequency in Japan and Mediterranean areas. So, Dr. Neetu has already discussed about the NER, that is the nucleotide excision repair pathway. This is the mechanism where the body takes care of the how to minimize the damage and repair it. So there are 8 complementation groups which has been classified, and these are the loci and the frequency. As you can see, for XPA worldwide it is about 30%, XP followed by XPC 27%, D 15%, and this XPV variant is common in Caucasians and about 23.5%, and they have an associated risk of melanoma. Now, this slide shows you the complex genotype-phenotype correlation of all the DNA repair disorders. So, as you can see that there are 10 clinical disorders which can be grouped and 13 molecular defects are identified. So, as you can see that for Xeroderma pigmentosum, again, XPC, XPE, and XPV variant, that is the gene involved is POLH. And if you have a symptoms like xeroderma along with cocaine, then XPB should be screened, XPD should be screened, xeroderma with other neurological abnormalities, then XPA should be screened first. Then you have trichothiodystrophy, where the genes are a little different. Then you have this cerebral oculofacial syndrome. It has again overlapping symptoms of XP. So Dr. Neetu has again touched upon the NER pathway. So you have 2 subclassification in NER. So one is global genome repair and the other one is transcription coupled repair. So in both these mechanisms, there are 3-4 steps like damage recognition first. So they identify where is the DNA damage has taken place, DNA unwinding where different sets of genes are involved, incision, dual incision takes place, and then the excised products are taken and then they are repaired and synthesized. So just looking at the indent scenario, we can say that XP was identified way back in 1995. So in one of the publication by Kulkarni et al., they studied about 7 cases of XP and already said that 29 cases have been reported in India at that time. So countries like Libya, Egypt, Israel and Japan, they said that high degree of consanguinity is there and they have a high incidence of this disease. A similar level of consanguinity is seen in South India. So in their group, out of the 7 cases, in 18% of the patients, they had neurological abnormalities. In another study, this was a multicentric study and our group is also involved in that. So in 2015, about 13 patients were screened for 3 genes, XPA, B and C. And in the out of these 10 families, in 6 families, homozygous mutation in XPA gene was identified and they all had moderate to severe mental retardation in those where neurological features were present. And in 2 unrelated families, they were from the same community from Maharashtra and they found an identical mutation, which is a frame shift, an XPA gene. So the authors commented that if neurological abnormalities are present, then one should screen first for XPA gene. This is another large cohort study, but no genetic diagnosis was done. Only the ocular features have been explained in this. This is from L.V. Prasad, Hyderabad group, and they studied 17 cases, and out of this, in total 56 of patients had 1 tumor, 6.7% had neurological abnormalities, And interestingly, parental consanguinity was observed in 74.4% of cases. This is a recent publication in 2024. 8 cases were published from Kolkata group. So they only studied the clinico-pathological perspective. And in 100% cases, they found cutaneous changes, ophthalmic in 75, and all children were born of consanguineous marriages. This is a study from Nepal. Why I have highlighted this? Because out of the 17 cases they have studied, in 15 of them they found this mutation R415X, and the authors said that this is one of the founder mutation in Nepal. So as Neetu said, that for the last 3 years she has a project where she is looking at the morphological pattern in the various complementation groups in XP, and she also did the genomic profile. So in 26 patients, WES was carried out, and in 21, she observed mutations in XPC and in 3 patients in XPA. And interestingly, this R415 was observed in our population also in 6 patients. So, and the other mutations are different and only present in either singleton cases. XPA variant, in 2 cases, we have observed this, the 555 plus is a splice variant. So, consanguinity is present in 30% of cases, and no neurological abnormalities were seen in this cohort. And based on the complementation group, no morphological difference was observed, and 2 patients had this C.555 plus 8A2G variation. So, a little bit about the worldwide scenario. So, study done in the Chinese population where the number of families screened were 10, and XPA and XPC, these were the common variation which was observed, and V was also found. And in Caucasian population, the mutation spectrum is totally different, and they observed in XPC. This is again a study where the patients are from different populations, and you can see that same variation in XPA, C.555 plus 8 was observed in 10 cases. So they have taken 2 Indian population, 2 patients from India also, and these variations have been observed in the Asian population, which are highlighted. So, based on the ethnicity from this study only, we can say that this particular variant, C.555 plus 8, is a common one, and XP variant in V is common in the Caucasian population. So, in another study from Mediterranean country, the authors observed that again there is a founder mutation, this C.1643 deletion. So this has been observed in patients from Italy, Spanish, Egyptian, Algerian, and Libyan countries, or the other Mediterranean regions. And the authors also suggested that a cost-effective molecular diagnosis is possible if they screen for these particular exons for XPA gene and exon 9 in XPC gene. So this shows that more study needs to be done, and we really need to identify the mutation spectrum in our population to identify if there is any common or founder mutation so that we can plan a cost-effective strategy. There is no functional clinical treatment of XP at present. early diagnosis and preventive measures to be taken care of to improve the lives of these patients, and definitely attempts are there to genetically correct the XP cells by retrovirus mediated gene transfer, and it held promise for the ex vivo cutaneous gene therapy using these retrovirus mediated transfer. Thank you.
Thank you, ma'am. So, after the genetic profile, let's review the clinical profile of the patient, which we saw. The commonest presentation, the commonest clinical finding we found was hyperpigmented macule over the photo-exposed site. We can call them lentigens if they are darkly pigmented, or freckles admixed with hypo and depigmented macules. In many of them also had actinic keratosis, which are these pre-malignant skin lesions presenting in the form of hyperpigmented scaly plaque. In addition, malignant skin lesions were seen in the form of basal cell carcinoma, squamous cell carcinoma, cutaneous horns. Many of them also had features of poikiloderma, which is feature suggesting photo aging in form of depigmentation, telangiectasias, and skin atrophy. Isolated telangiectasias were also seen, and generalized atrophy and xerosis was a common feature in almost all of them. Hyperpigmented macules on the palm and sole was seen in around 1/3 patient. Oral mucosal examination should not be ignored. We should do it thoroughly because the anterior 1/3 of the oral cavity, particularly lips and tongue, they are prominently UV exposed sites, and there are frequent reports of pre-malignant as well as malignant lesions in the oral cavity. In our cohort, 18 of them had oral mucosa involvement, majority had involvement of the lips, and 6 patients also had tongue lesion. So involvement of lips in our patients was seen in the form of hyperpigmented macules, actinic cheilitis in the form of depigmentation, scaling, and atrophy, and tongue involvement was seen in the form of punctate erosions over the tongue in 6 of them. Though we did not see any florid malignancy in the oral cavity, but we could not exclude pre-malignant lesions because they were not biopsied very frequently. Nail involvement is also an important finding which we noticed. Many of them had the nail involvement in the form of photoonycholysis. There was nail plate thickening, subungual hyperkeratosis, discoloration, orangish discoloration of the nail. When I reviewed the literature, the term is used photoonycholysis, and if it affects multiple finger, you call it polydactylous photoonycholysis type 1. This was an interesting patient we saw where a young girl presented with this subungual mass. Clinically, we thought of subungual fibroma, fibrokeratoma, keratoacanthoma, even squamous cell carcinoma came to our mind. This was a dermoscopy showing a yellowish structureless area. There was adherent scaling, and histopathology biopsy was done, and the histopathology showed multiple homogeneous eosinophilic collagen fiber arranged haphazardly in the dermis, which stained positive with mesentericum, and there was mucin stained positive with Alcian blue. Thus, the features were suggestive of keloid. And when we reviewed the literature, we found that in XPC, there is oxidative stress on the collagen fiber. This keloidal tendency is commonly seen. We went back and examined the patient clinically, and we could see keloidal lesion elsewhere on the body as well. Cutaneous malignancies is a major cause of morbidity and mortality in this population. In our cohort, we saw multiple cutaneous malignancy ranging from benign to malignant. The most common was basal cell carcinoma, and it was followed by multiple squamous cell carcinomas, malignant melanoma, angiosarcoma, and benign vascular tumors such as pyogenic granuloma. When we evaluated them topographically, we found that face was the commonest site, particularly periocular, cheek, and nose. And if we classify them based on the WHO classification, majority belong to high risk category. And if you again classify topographically, periocular and scalp and nose as well resulted in high risk skin lesion, where the sites like forehead, chest mostly had low risk skin lesions. While evaluating these patients, we could assess that the malignancy burden in the population was variable, even within the same complementation group. So we thought of creating, we felt the need and then thought of creating a severity score so that we can give an objective assessment of malignancy burden in these patients, which will help in prognostication, which will help in monitoring the therapeutic outcome. And on review of literature, we could find these 8 factors, clinico-pathological factors, which were divided, which were given various cutoffs and were divided into high risk and low risk. And on statistical analysis, we could see that it had significant statistical significance, sensitivity and specificity to classify it into 3 groups, which were mild, moderate, severe, and these factors they correlated well with the dermatological assessment of severity. So based on this, the score ranges from 0 to 9. From 0, 1, 2, 3 is the mild affection. From 4, 5 and 6, 4 to 6 is the moderate, and 7 to 9 is the severe affection of malignancy burden. I would invite Professor Namrata Sharma ma'am to discuss the ocular involvement in these patients.
Thank you. I would like to thank Dr. Neeti for making me a part of this CGR forward transfer. Yeah. I would be discussing the ocular manifestations of which occur in Xeroderma pigmentosa. I think the earliest ocular symptom which has been reported is photophobia or watering in 21% of the cases, and this occurs more in the younger age as compared to the adults. The lids are the most frequent part which are involved almost in 80 to 100% of the cases with loss of lashes, atrophy, entropion, squamous cell and basal cell carcinoma, and cornea is involved in 17 to 40% cases, and there may be features of dryness, keratitis, band-like nodular keratopathy, ulceration, corneal opacities, vascularization, and perforation in some of these cases. In conjunctiva, 18% of the cases are involved with telangiectasia, xerosis, chronic congestion, and pigmentation. This was a study which was published, which clearly shows that photophobia is the almost universal feature in these cases. And apart from this, there can be excessive lacrimation, and this may also lead to blurring of vision, which is less common, corneal injection, and corneal clouding. Notably, there are carcinomas as occur in the skin, the lid squamous cell carcinoma, basal cell carcinoma, and even the limbal squamous cell carcinoma as well as the conjunctival squamous cell carcinoma may also be there. This is the distribution of the reported ocular cancers, and the ocular cancers are most often present in the eyelid, followed by conjunctiva, limbus, and then cornea and orbitus virtually similar. These are the ophthalmic manifestations of Xeroderma pigmentosa, which has been reported from United Kingdom. And again, in these cases, 93% of the patients which were recruited had ocular involvement, so as to say that almost all of them will have it. And photophobia again remains the primary concern as far as the patient is concerned. But there may be other features also, such as the melanosis, which may be there, and also the corneal neovascularization and keratopathy. And it is the XPC which has higher ocular pathology score, more surface abnormalities like conjunctival congestion, pinnicula, and corneal scarring. This is yet another cohort which has been reported from Brazil in 21 eyes, and burning, tearing were important features, and they have actually divided based on the variant, the XPV and the XPC, and the involvement both burning and tearing are major involvements which are there for both the variants. As far as the demographic data was concerned, the mean age of presentation of the cohort that was studied is 13.8 years. Mean age of onset of the first symptom was 1.6 years. It occurs in males and females both. Consanguinity plays an important role, as has also been highlighted earlier, and so does also positive family history. The skin phototype is seen, type 5 is seen in most of the patients, and number of the patients who do have cancerous lesions were 12 out of 21. And age of the first cancer was also 13 years, which was on average. The ocular features of in Xeroderma pigmentosa, as expected, all patients did have photophobia. Conjunctivitis was the most common observed ocular feature, followed by conjunctival melanosis, blepharitis, and corneal clouding. And the least observed feature was ectropion, entropion, lid atrophy, and loss of lashes. And only 3 patients had ocular tumors. And the various features have also been highlighted in the tabular form on the right side. Now, it is important that we also grade the ocular severity based on the 1 point which is given for each feature and 2 points given for neoplasia. And the mean ocular severity score of this cohort was 4.7 plus minus 2.1, which was based on the features which have been discussed and which have also been highlighted. So these are some of the pictures to show that there is conjunctival melanosis, entropion, and loss of the lashes. Then conjunctival congestion, which is an universal feature, almost universal, associated with photophobia. Then pterygium and corneal clouding is also there. The corneal clouding can become quite severe as the cornea opacifies and there is neovascularization. The ocular and the periocular neoplasias are also present. And this patient right eye, you can see that there's complete obstruction of the right eye by the exophytic tumor, which had occurred 1 year back. And in the left eye, there's loss of vision, which was there 5 to 6 months ago, mainly because of the infiltrative and the ulcerated lesion over lateral aspect of the left eye. And it is very difficult to treat these tumors also because of the fact that surgery becomes almost impossible to do in these cases. This is yet another patient in which right eye bulbar mass is there, which is there in the right eye, and the left eye pigmented lesion is there, and cytology shows melanization of the cells, and both eyes had conjunctivitis, conjunctival melanosis, and lid atrophy. So these are the various parameters, and there are certain parameters which play an important role as far as the ocular severity score is concerned. Notably amongst these are the age, the DPS score, the malignancy severity would depend on these factors. And to summarize, as far as the cohort is concerned, XPC was the commonest variant in Indian subcontinent. And because of poor sun protection behavior, a high frequency of ocular surface abnormalities and malignancy is expected. And this also results in high degree of morbidity. The mainstay of ophthalmological management, as suggested by the symptoms, is that we have to give symptomatic treatment for dry eyes, also address the lag ophthalmos, the ectropion, pterygia, which, if not impinging on the visual axis, can be left alone. But sometimes you do like to remove it because you have to rule out the carcinomas. Then ocular surface as well as lid cancers can be there, and subsequent to this, there can be strabismus and double vision. It is important to recognize these features early and treat them because that would help in reducing the long-term complication and the sequelae of the disease. And I think in addition, ophthalmologists do play an important role in advising and facilitating adequate ophthalmic UVR protection as well. I think that is all. So again, I would like to thank Neetu for involving, because we've been seeing all these cases, but you put it in an organized manner and evaluate them completely. It makes a different sense totally. Thank you.
Thank you so much, ma'am. So on further morphological analysis, I wanted to emphasize one thing, that we could identify that there were two important phenotypes we could assess. Group 1, who had involvement of, he had which had generalized involvement of both photoprotected and photo-exposed sites. There were hyper as well as hypopigmented macule. And then there was group 2 where the involvement was restricted to photo-exposed site and there was significant sparing of the photoprotected site. Within the group 2, we could identify a subgroup which we named as group 2A, which was characterized by these discrete hypopigmented idiopathic gutted hypomelanosis like macule over the lower legs, while in group 2B we could not find. So this is group 2A, characterized by discrete hypopigmented to depigmented macules over the lower leg, usually without accompanying hyperpigmented macule. Some of them may had here and there few hyperpigmented macules. We were wondering whether this photo-distributed versus generalized involvement, is this a difference in the phenotype of the disease or it is just a continuum of disease severity? They are starting as photo-distributed, becoming generalized, and this is important because they may have difference in the prognosis, they may have difference in the need for stick sun protection, need for lifelong continuation of isotretinoin therapy. So we did, though the sample size is very small, but we did attempted some statistical analysis. And we could clearly see that the group 1 with generalized involvement had higher photoaging as analyzed by DPS score, which Dr. Ria will discuss in detail, had higher ocular severity scores, though the malignancy severity score were comparable in all three groups. But we had this impression that group 2A was a milder group, and we could see this in the fact that the group 2A, the age of onset of the malignancy was delayed compared to group 2B and group 1. And also the high risk malignancy, though they were there in group 2A, but it did not have a propensity to have more high risk compared to low risk malignancy. If we compare the age, there was group 1 and 2A, there was a difference not statistically significant, but from group 2B, which is actually the most severe, the most of the high risk malignancy were seen in group 2B. There was a difference in the age. The sun protection behavior was comparable among the three groups. So we concluded that there are two phenotypes, generalized and photo-distributed, but both of them should be advised stick sun protection and oral isotretinoin as a chemoprophylaxis. Generalized involvement will have higher photoaging, higher ocular severity score, but if you see a photo-distributed variant with discrete hypopigmented macule, it represents a milder variant with later onset of oculocutaneous malignancy, and you may advocate a late initiation of isotretinoin in this group. I would now request Dr. Ria Ahuja to discuss the dermoscopic finding in this cohort.
Thank you, ma'am. Good afternoon, everyone. So we also evaluated photoaging in our cohort. Broadly, aging can be categorized into two categories: intrinsic or chronological aging, which is genetically determined, and extrinsic aging, which is driven by various environmental factors, including pollution, smoking, the most important of which is UV radiation. Hence, extrinsic aging is also termed as photoaging, and this can cause either epidermal damage, which can lead to freckles, solar lentigenes, actinic keratosis, and a more rough or porous skin texture. Damage to the dermal proteins, which can lead to skin laxity, sagging, and wrinkles, and even vascular damage leading to telangiectasia and purpura. Now, ordinarily, in a healthy individual, because the repair mechanisms are intact, they are protected against this damage. And however, in XP patients, these patients exhibit accelerated photoaging because of unchecked and cumulative DNA damage. So it is thought, and we also thought, that XP patients can probably serve as a model for photoaging, and we wanted to evaluate this in this cohort. We used two scales, the age-old Lugao photoaging tool, which basically characterizes patients into four categories based upon the intensity of pigmentary changes, intensity of wrinkles, and the need for habitual foundation use. So no wrinkles, wrinkles in motion, wrinkles at rest, and post-wrinkles all over. We've also used this recently validated and more objective dermoscopic photoaging scale, which basically divides the face into four regions. So the forehead, the bilateral cheeks, and the chin. And across these 4 areas, we score these patients in 11 features, that is yellowish discoloration. So yellowish discoloration and yellowish papules, which basically represent the degree of solar elastosis, the presence of white linear areas of scarring, atrophy, presence of mottled hyper and hypopigmentation, that is hyper and hypopigmented macules, more well-defined hypopigmented macules called lentigens, telangiectasias, actinic keratosis, comedons, more deep wrinkles and superficial wrinkles, which are differentiate based on the fact whether they can be obliterated by skin stretching, and coarse crisscross wrinkles. So maximum score here is 11, so 11 into 4. We saw that the DPAS score ranged from 4 to 21. And the Gagao photoaging score on this scale, the patients mostly had either a mild or a moderate or advanced subtype. None of them had a severe subtype of photoaging. In general, there was a good correlation between these two scores. If you look at the DPAS score only, the mean DPAS score was only 13. The maximum score can go as high as 44. So most patients exhibited only a mild to moderate degree of photoaging. Upfront, we thought that this was probably because most of the patients in our cohort were children. That was one reason. The other reason was that the patients in this cohort had a Fitzpatrick skin type of 4 to 5. That was the other reason. But when we looked at all these domains, we realized that some domains were completely unaffected or minimally involved. For example, none of these patients had yellowish discoloration, yellowish papules, crisscross wrinkles. Even superficial and deep wrinkles were present in a minority of patients. The major domains which were affected in these patients were actually pigmentary changes and vascular changes. So, pigmentary change in the form of hyper and hypopigmented macules, more well-defined hypopigmented macules, lentigens. We saw some hypopigmented macules at the very classical amoeboid or polypoid borders seen in IGH-like macules. The presence of telangiectasias, scaling, and actinic keratosis. Presence of superficial wrinkles and deep wrinkles, but they were present only in a minority of patients. So what was the reason behind this differential involvement in the photoaging domains? So understand that photoaging is caused both by UVA and UVB. UVC doesn't penetrate the ozone layer. Now UVB, it has a shorter wavelength. It can penetrate the epidermis and can reach up to the superficial dermis only. Now UVB causes DNA damage by forming pyrimidine dimers. This DNA damage is repaired by nucleotide excision repair pathway. UVA, on the other hand, has a much longer wavelength and can go right up to the reticular dermis. And UVA causes DNA damage by reactive oxygen species, which leads to the formation of oxyguanine photoadducts. This DNA damage is repaired by base excision repair pathway. And we all know that in XP patients, it is only the nucleotide excision repair pathway which is involved. Hence, these patients had features of predominantly epidermal or superficial dermal photoaging in the form of either pigmentary changes or vascular changes. So basically, hypopigmented macules, telangiectasias. Very few of these patients had wrinkles, and none of these patients had solar elastosis or crisscross wrinkles. In fact, there are studies which say that XP patients, rather than developing skin laxity, they develop skin tightening because of an unknown mechanism, and solar elastosis, which is directly proportional to the amount of UVA causing damage to the dermal collagen. This is virtually absent in XP. So to conclude, XP patients exhibit predominantly epidermal photoaging in the form of pigmentary and vascular changes, and it is UVB rather than UVA which ultimately causes photoaging and also increased risk of skin cancers. Thank you.
Thank you, Ria. In addition to dermoscopic analysis, we did histopathological analysis with the help of Sudhir sir and Dr. Shivangi from Department of Pathology. We could clearly see that the basal cell carcinoma was the commonest malignancy, but we had one interesting finding, and that was that most of the basal cell carcinoma here, which we were analyzing, were histopathological high-risk subtype, which was in contrast to the general population or the reports from country, where majority of the BCC are of low-risk type. So we were hypothesizing that maybe the increased recurrence in these patients is not only because there is a genetic defect, but also because of the type of tumors which we are dealing with. When we evaluated 41 basal cell carcinoma from 22 patients and classified them on the basis of WHO 2023 update into the low risk basal cell carcinoma and high risk basal cell carcinoma, we could find that the commonest was nodular BCC, which is low risk in 41.46%, and superficial was seen in 1. But there was a high frequency, unexpectedly high frequency of basosquamous carcinoma, infiltrative BCC, and mixed histopathological subtype. Mixed in the sense there was low risk component, but as well a high risk component. So overall, 43% had a low risk histopathological type and 56 had high risk histopathological type. I'll give you some examples. Like this is a girl presenting with this hyperpigmented scaly plaque. She had a classical nodular BCC. On histopathology, we could see nodular aggregates of baseloid cells in the superficial and mid-dermis, retraction cleft, presence of pigment in the tumor island as well as in the stroma. But let's see some few examples of basosquamous BCC. This man presenting with this hyperpigmented nodular scaly plaque over the chin area. On histopathology, we could see that there were basaloid island present in superficial, mid and deep dermis, and on high power we could see that in the center of these island there were cells with squamoid appearance. They had abundant cytoplasm, eosinophilic cytoplasm and vesicular nuclei suggestive of basosquamous differentiation. Squamous differentiation within a basal cell carcinoma. We could also see multiple necrotic keratinocytes in the center of the island. This is another example of basosquamous, again a nodular lesion in the infraorbital area, and on histopathology there were island. So on low power you think this is a classical example of basal cell carcinoma. Basaloid nests were seen in the superficial, mid and deep dermis, but on high power you will appreciate the cells with squamoid differentiation in the center of these tumors. Infiltrative BCC were again the third most common type of malignancy. For example, this girl presenting with this hyperpigmented scaly plaque on the ala of the nose, and histopathology showed in the superficial, mid and deep dermis these elongated. So here you can see an elongated nest of basaloid cells and surrounded by a fibrotic stroma instead of a myxoid stroma of a routine BCC type. This was an example of mixed histopathology where we could see both nodular and infiltrative component in the histopathology. And this is important because then it mandates a careful analysis of feature. You can't leave it at nodular BCC. You have to examine deep and see that there are elongated nests and surrounded by a fibrotic stroma. So they are kind of penetrating the fibrotic stroma in the dermis. This was another example of mixed BCC, mixed histopathology. This nodule, when it was biopsied, we could see there were nodular component, adenoid component and infiltrative component. Among the adenoid component, there was mucin deposition between the nodules of BCC, basaloid cells, and this infiltrative component, again elongated nest surrounded by a fibrotic stroma. This was a low risk histopathological type of superficial BCC, where basaloid cells were limited to papillary dermis, and this was an interesting histopathology. So I included nodular adenoid BCC presenting as hyperpigmented scaly plaque on the forehead, and the histopathology showed these nests and cords of basaloid cell in the superficial, mid and deep dermis. They are separated from rest of the dermis by clefts, and there is mucin deposition between these cords of basaloid cells. Basosquamous carcinoma is important because we know this is an aggressive variant of basal cell carcinoma, has high local recurrence, high lymphadenopathy, high systemic metastasis. In the local recurrence, as this study has shown that if you do wide local excision, 12 to 45% risk, and Mohs micrographic surgery, 4% risk of recurrence. So this knowledge will help you to decide what kind of surgical excision you should go for. Similarly, when in the sporadic population recurrent BCCs were evaluated, most of them were from infiltrating or micronodular histopathological subtypes. And BCC with mixed histology, again there is a high risk of recurrence, and most micrographic surgery is recommended. So I will now request Professor Somesh Gupta to discuss the Mohs micrographic surgery in the management of skin tumor in these patients.
Thank you, Neetu, and thank you for taking up XP as your research interest, because I have the oldest, longest follow-up of 17 years, which the patient is still coming to us. Came as a female child, now she is an adult. And the single most important factor which stood between her and death was not our services, but her father, who was meticulously taking care, and she kept developing skin cancers. We kept removing it for all these years. So we need a supportive family. Most of the patients will not have, because majority of them, the family, they're already, if they are not well to do, they would lose interest soon in the child, and most of the children will not survive to the adulthood. So this before coming to Mohs surgery, we were doing just surgical excision or using non-surgical and non-ablative treatment. So this was the largest cohort with longest follow-up in Indian setting for basal cell carcinoma. And what we found is that the treatment failure was more often seen was in non-surgical, non-ablative treatments, 30%, and no immediate treatment failure with surgery. So surgery remains the treatment of choice. And this cohort had 5 XP patients and 3 albinism patients. So obviously, the Mohs surgery is the treatment of choice, particularly in view of Neetu's findings, which suggest that these patients are more likely to have high risk histopathological types as compared to other the garden variety of skin cancers. So just most of you must have read about it in your undergraduate days. It was first developed by Dr. Frederick Mohs in 1930s, and it is like the treatment of choice for high risk skin cancers for sure, and recurring skin cancers. But it can also be used as a tissue sparing surgery for low risk skin cancers located, especially as Dr. Namrata showed, close to the eye or other structures of functional importance. It offers high cure rates for the treatment of basal cell carcinoma and squamous cell carcinoma for sure, but I will show you that it is useful in other skin cancers as well. So the Mohs micrographic surgery is the standard of care for selected BCCs and SCCs, and commonly and increasingly used for melanoma and other tumors. If you compare the Mohs surgery with the conventional wide local excision, in Mohs surgery we examine 100% of the peripheral and deep margins, while in see here, if you wide local excision, you just examine 1% of the margin, and we have to report it as clear. Margins are clear, which is not entirely true, because we are just examining 1% of the specimen. And apart from that, there are certain advantages of wide local excision, that it's more economical, and not all skin cancers are to be treated with the Mohs micrographic surgery, because it's a very demanding procedure, requires a lot of manpower and infrastructure to do it, and the most expensive thing is the surgeon's time. So this is not freely available at many centers, but now we are doing it. So clinical significance of Mohs surgery is that it reports excellent 5-year cure rates for non-melanoma skin cancers and basal cell carcinoma and squamous cell carcinoma, and it is much more useful for recurring BCC, where the conventional wide excision is largely unsatisfactory. So Mohs surgery can also be used in less common tumors like dermatofibrosarcoma protuberans and microcystic adnexal carcinoma, extramammary Paget's disease, and Merkel cell carcinoma and sebaceous carcinoma. And Merkel cell carcinoma and sebaceous carcinoma are highly malignant, and so these are the indication of Mohs surgery. Right. So here you can see that all margins are taken care of because horizontal sections are taken, unlike in usual biopsies where you do the vertical sections like this. In this, the histopathological examination done in the vertical sections, so it misses most of the part of the tumor. Now, as I already mentioned, that higher risk patients are more likely to be benefited, like immunocompromised, those with the Xeroderma pigmentosum or basal cell nevus syndrome, prior irradiated skin, patients with history of high-risk tumors and recurrent tumors. And among the tumor characteristics include the positive margins on recent excision. These are the best candidate for Mohs surgery because otherwise the recurrence is the rule. And aggressive features of squamous cell carcinoma like poorly or undifferentiated perineural invasion or perivascular invasion, and spindle cell types, and Barcelot depth of 2 millimeter or greater, and Clark level 4 or greater. And on the other hand, the aggressive features that are high risk of recurrent BCC include the aggressive histologic subtype, Neetu already mentioned about it, perineural involvement, and metatypical or keratotic. Now, there are certain low risk areas like area H, the mask area, that is the high risk type. Then area M, which includes cheek, forehead, scalp, neck, jawline, and pretibial surface, and low risk area include trunk and extremities. And on the other hand, this is the high risk area. In the interest of time, I will skip this. We are just about to reach our limit. So, but this slide is important because this efficiency of Mohs micrographic surgery in basal cell carcinoma, the cure rate is 99%, while wide local excision 87 to 96%. And in recurrent, the cure rate is 90 to 93% with Mohs as compared to 83%. So recurrent BCC is a better indication of Mohs micrographic surgery. Similar figures for squamous cell carcinoma are 90 to 99% for primary and 90% for recurrent with Mohs, and 90 to 95% for primary and 76% for recurrent. And melanoma is in situ 98% cure rate as compared to 83 to 85. So while the melanoma can be a fatal tumor, so it's even a better indication, but many people will not use for melanoma. So just to come to our own cases, so we started in last year in February. The director and Dean Academic Verma inaugurated our Mohs facility, which was like we were trained by Blade and Light team from US. They came on their own and trained us and our technicians for this. And since then, we have treated 21 lesions in 20 patients with 11 male and 9 female, and mostly Fitzpatrick skin type 4 to 6. And BCC was obviously the commonest tumor, 17, SCC 2, and Bowman's disease 2. So these are various sites. And SCC also glands penis, I especially mention here because it is penile conserving surgery. Otherwise, amputation of the penis is the treatment. So patient sexual life and quality of life is maintained. So these are XP patients. So she had 2 tumors at the time of presentation, both one on the nose and one on the cheek. And we did more surgery for this as a tissue conserving procedure. And flap was used for VY flap and transposition flap for repair on both the lesions. And these are the follow-up pictures. And this need to mention, but I would take a minute for this. So we propose the use of imiquimod as an immunopeeling agent on the whole face, and because there is a field cancerization, we don't know where the cancer is, and we don't know where the cancer is not there in so many pigmented lesions, it is almost impossible to map them. So treat everything on the skin surface using an immunomodulatory agent, imiquimod. So this paper, which was published in Indian Dermatology Online Journal, remained the most accessed article for almost a year with more than 40,000 access. So possibly there is a demand for research in XP, and it's, I would not say neglected disease, but we need much more focus on this. Now today morning OPD he came again. So earlier he was using all days imiquimod. Now he is using 2 times a day, and effects are still maintained. So this may be a good way of dealing with this. And we coined this term, Dr. Vishal Gaurav, our senior resident, he coined this term, immunopeeling. So there is no such term exists in the literature, maybe to emphasize the importance of this. Now he came after immunopeeling, the one skin cancer on the nose remained unresolved. So we had to do Mohs in him. And this is the today's follow-up picture. This patient comes from Nepal. Now I must highlight here that this patient, it is covered by this black bar, but he was operated with the conventional wide excision and he developed ectropion in one of the eyes. So the vision is much reduced now in that eye. So it is why it is important to conserve the tissues, especially on the face and in high risk area where of functional and aesthetic importance. So just take home message is that Mohs is the solution, and I must acknowledge a large number of people who have been working on Mohs micrographic surgery. Shafak, of course, Dr. Kanika, Dr. Neha, Dr. Ria, Dr. Aman helped with this presentation, DPR team, the Department of Pathology, Dr. Sudhir and Dr. Shipra, Department of Plastic Surgery, Oculoplastic Surgery, and ENT. Sometimes they ask us to remove the tumor with the Mohs, and then the complex repair is done by our colleagues in other departments. Our technicians, Maya, Anubhav, Anwar, and of course, our resident doctors. And this was the time when it was inaugurated by in collaboration with Blade and Light team. And of course, I can't thank everyone here. I have to skip a few names who are important. Thanks.
Thank you, sir. So in conclusion, we can say that based on the cohort we have, XPC is the predominant variant in our cohort. There are two major clinical phenotype, generalized and photodistributed. There is IGH lesion on the lower leg suggests a milder variant, and they are important to observe. Scores like sun protection, behavior scores, malignancy severity, and ocular severity can be used to monitor the disease activity. Dermoscopic analysis suggests that they have predominant epidermal aging. Histopathology suggests BCC predominantly have high risk histopathological types, so Mohs micrographic surgery is important in these patients. In addition to helping them in all other possible ways, Organization of Rare Disease India Bangalore is also helping them financially, and now they have started this website for crowdfunding, and they are generating funds for their treatment. Thank you so much. Thank you all for your patience hearing. Special thanks to my students working on this project, Shafak and Devesh. So any questions? We are running out of time, but any quick questions we can take. Questions or comments?
What is the longest duration of isopretron use reported in these patients?
Sir, lifelong, sir. So in the 106 patient series, they have followed up patients from 1990s to 2025, 2024. And they have around 40 years they are using isotretinoin.
Same dose?
Same dose, yes, sir.
Same in those patients?
Sir, there was a report, they have shown some patient had some mucocutaneous, some patient had liver abnormalities, but overall it is a safe drug, but there are occasional cases with side effects. And the dose need to be adjusted in those. Then.
5 years.
Yes.
also a very strong message for using isopropyl in other conditions where we are afraid that yes, you should not use for it after a certain length of time.
Right.
Thank you. Well done.
Thank you so much.